Hello everybody, my name is Raisha Noorani. I'm a GPST3 in London and I've been doing a series of CSA videos to help you prepare and pass the CSA. Now the first few videos that we did were very much an overview of the entire CSA and how to prepare for the examination. What I want to do in the next couple of videos is really concentrate on the structure and what you're actually going to do in the consultation. So in this video we'll talk about the first 5 minutes and then in the following video we'll talk about the next 5 minutes. For the purposes of this one, we're going to stick very much to a standard clinical case situation, and maybe in further videos I might try and see if we can do something on things like information giving or breaking bad news. But let's stick to bread and butter medicine and talk about the first 5 minutes. Now when you look at the first 5 minutes and correspond it to the mark scheme, essentially the first 5 minutes are your data gathering part of the mark scheme. As you know, you're being marked in 3 different domains. One is data gathering, the other is clinical management, and the last one is interpersonal skills. Interpersonal skills is woven into the entire consultation. First 5 minutes are pretty much where you're going to get your data gathering marks, and the second 5 minutes are where you're going to get your clinical management. Now, when we talk about history, you have to think when you're gathering data for this history that there is a purpose behind it. So it's a purpose-driven history, and I think before you start going through what do I do and what do I ask, you really have to understand that concept. So this is not med school days when you're sitting there and you've got an hour to chat to a patient and talk about what's been going on. You have 5 minutes, and because you have 5 minutes, you need to make sure that this history is working towards something, and that something could be working out what's going on, but more importantly is, rather than diagnosis, the goal you're working towards is, what am I going to do with what is being presented in front of me? And that's the aim. And if you know where you're trying to go, that journey in your first 5 minutes is a lot smoother than if you're aimlessly trying to go in different directions. So it's a focused history, a purpose-driven history. So I would just bear that in mind very much, that you have a goal that you're working towards. Now, what you need to cover in the first 5 minutes. So you need to know how to take a history. You want to cover the red flags. You want to ICE, so ideas, concerns and expectations. You want to get some social context behind this patient, and you want to do an examination. So that's 5 things in 5 minutes. So I cannot repeat this enough. There is a lot to cover when it comes to taking a history and doing the data gathering. So you really have to be slick in how you're going to approach this. So let's talk about taking a history first. You do not need me to teach you how to suck eggs. You all know how to take a clinical history. You all know what kind of questions to ask. So what I would really give you tips on is specific bits about that. So the first is this idea of a golden minute. Almost all the educators, all the courses talk about the famous golden minute where you allow a patient to talk. And this is true if you have a normal patient who comes to see you, and you know they come in and suddenly they're going, "Doc, this happened and that happened, and then I felt this way," and whatever else it might be. I think the CSA is very different because it is a contrived situation. You're put into an artificial place, and they want to see how you manage and how you gather information. So they're not going to give you necessarily an authentic experience of a golden minute. And I think that phases a few people, because you kind of go, "Oh, how can I help?" and you're expecting a huge response. But actually what actors usually present with is an opening statement. So they will give you a few words and then it is your job to then dig into that a bit deeper. So I wouldn't forget about the golden minute, but what I would say is a better model for how you're going to approach it in the CSA is to do this idea of starting with open questions and then drilling down into the closed questions. So you're still gathering a lot of information in those first few minutes, but then you can focus it as you go down. So a patient will come in and they'll say something like, "Oh, doctor, I have chest pain," and that's all you'll get. "I have chest pain." So you can go, tell me a bit more. Yeah, it started 2 weeks ago. and then you think, okay, and then what you're doing is, rather than waiting and it's just being silent, you're asking more sort of open related questions. Okay, it started 2 weeks ago, tell me about how it was when it first started. Or you mentioned chest pain, can you tell me a bit more or describe what this pain is like? So your questions are still very much open, but they're just a bit more guided than what you'd get in real life. In terms of the other thing, I think, with clinical history is you have information, you know what the patient's background is, you know what their drug history is. So I think you really have to make a judgment call on what's important and what isn't important, and whether it's relevant, because you cannot do all the different parts of your clerking if you've got another 4 things you need to cover. So yes, family history might be very important in someone where you're talking about a cancer diagnosis. Family history will not be important in a standard viral ERTI. So I think you just need to make that judgment call when you're seeing the patient. You know, some places the drug history is very important because there are medications that interact. Other places actually a drug history makes absolutely no sense. And I will come back to making that judgment call, because it's a very important concept when you're taking clinical history, about how you decide what you're going to ask. So that's history. Let's talk about red flags. Now, this is something that gave me a huge amount of anxiety when I was revising for the exam, because I thought, if I miss, you know, a single red flag, someone will, you know, pick me out of that consultation room and declare me unfit to practice. And it doesn't work like that. But it is, there's a real palpable fear that you don't want to appear unsafe in this exam. That's not true, and all of these course educators that bang on about, oh, you can't miss a single red flag, and give you a really hard time over it, I think need to understand that when you're being a safe doctor, you're getting information and you don't need to focus on every single red flag there is, nor is that a good focus history. That's not what this is about. What you're doing with your red flags is you're trying not to miss anything sinister. So the easiest way that I find working with red flags is, rather than going, oh, if someone presents with a cough, I need to ask about all these symptoms, I think a better way to do it is, okay, a patient's presented with something, what do I need to rule out? So this patient has presented with chest pain, I need to rule out that it's not an MI, it's not a fatal sort of arrhythmia, it's not a pleuritic pneumonia or pulmonary embolus. So those are, you know, those are the big things you're ruling out. So then your red flags are more diagnosis driven or something more sinister. So you're going, do you get shortness of breath? Does the pain come on when you take a deep breath? Do you feel like your heart is racing? Do you feel like your heart is skipping a beat? You know, those sort of questions. And as soon as you're getting the answers, you're kind of tucking away going, well, it's not this, it's not this, it's not this. Actually, I'm not worried about this. And I think that flipping your red flags over so that they refer to all the major diagnoses and working out what you need to ask for those, rather than going, chest pain, I've got a list of 10 questions, cough, I've got a list of 10 questions, you know, hemoptysis, I've got a list of whatever. And if you do it that way, I think it's just harder to process that in an examination type of environment where you don't necessarily have the time to really focus on what you're doing, and there's so many other distracting features around you. So that's your red flags, and essentially your history and your red flags give you an idea of what's going on. Then what you want to do is you need to ICE a patient. So you need to ask about ideas, concerns and expectations. Now this is important because you've started off, you've taken a history and you're thinking, oh God, you know, this is sinister, this is a 2-week referral, this patient may have cancer. If you don't know where your patient's at, everything can go downhill. So the point of asking ICE is because what your thoughts are and what your patient's thoughts are might be on completely different levels, and it's kind of bringing that together so that you're equal and you're kind of on the same level, so you can impart that knowledge that you then have. I think if you understand why you're doing it, you're a bit more slicker when you ask ICE. So rather than going, oh, what do you think is going on, or what are your ideas about what this is, what you're then doing is going, okay, so you've told me this, and you mentioned that you know, this has happened a few times. What do you think here? That actually sounds a lot better than a blanket statement. In the same way, when you're asking about concerns, being able to relate to what the patient might have already told you allows you to express or question someone's worries and concerns a lot better than blanket statements. Now, I'm not going to give you a statement for what you need to say for ICE. I think anyone who does that is wrong, because actually it has to come across really natural. And yes, you might get a tick going on, she asked about ICE. What you won't get is the higher marks of sounding like you're very good in your interpersonal skills, because if it doesn't come across natural, it really, I think it's probably an examiner's pet peeve, because everyone knows they need to ask it, but it's the way you ask it, and I think that's something you need to develop yourself. But if you understand why you're asking ICE, and that's you trying to kind of gauge where the patient's at and seeing if they're going to be able to follow you in terms of what you're thinking is going on, then actually you're already in a good place of working out how you're going to then ask about ICE. So that's ICE. The other thing is social context. Now, I put this as a separate thing because I don't think there's a single CSA case where social context is not important. I don't think there's a single GP consultation where social context is not important. And the reason I say this is because you can follow a guideline and you can do, your standard medicine. Whether that really helps a patient, whether you find that the patient listens to you or is compliant with their medication, and actually everything about management depends on the social context that you're working with. So for example, if you see a depressed patient and he's got a good job, he's got a wife who's worried about him and is looking out for him, work are really supportive, and he comes to see you, you will respond very differently if you see a depressed patient who lives on their own, is socially isolated, is unemployed, and suddenly you're thinking, what I would have done for patient A, despite them having exactly the same symptoms as patient B, is actually very different, in the same way that you would manage most conditions. So you cannot do medicine, you cannot treat patients if you have no idea of what their context and their background is. And it explains why medicine then becomes an art, and why you're then changing the way you treat something depending on how where someone is at that point in time in their life. Now, social context, I think, actually even more than ICE, if you miss it in your exam, I think that will probably end up as a fail, because your management is so dependent on what's going on in that person's life. So I would always ask about the social side of things, and you have to be a bit nosy. And actually, I don't think you can be a GP without being, without prying a little bit into someone's personal life, and that could be asking about their relationships, asking about who else is at home, asking what they do in their free time, asking about work or studying. And then usually at this point in social history, I would do the other things like smoking and what kind of diet or exercise and all of those things that they have. So I think most people will ask about social context, and I think it's almost, that is the thing that you cannot miss when you're doing that history taking. And then lastly, you've got examination. Practice. Examination is the most important thing to practice, because there is nothing like a CSA exam to make you think, oh my god, I don't know how to listen to heart sounds, or I can't remember how to examine a shoulder. So you do have to practice it, and what I would say is practice doing an examination in less than a minute, because by this point you really don't have enough time. And it's very easy to spend a lot of time on data gathering. So what you want to do is be very slick and work out the cardinal features of what you need. And actually, examiners do expect you to get up and start examining a patient. They will stop you if they will want to, or they will wait till you complete the examination and then give you the results at the end. Some patients have signs, so you might find, they're crying out in pain if you decide to touch their abdomen, or you hear a heart murmur. So not only do you have to be able to examine, you also have to be able to switch off from what's just happened in terms of taking a history and focus on what your findings might be. So that's a lot. That's a lot of things in 5 minutes. And actually, I think the best way to think about how to do that many things is by practice. So you really need to practice sort of most trainees, I would say, tend to spend a huge amount of time on data gathering for two reasons. A, because it's a lot, and also B, because we're a lot more comfortable with taking a history when we're still trainees than organising and sorting out a management plan. So that's quite important, that actually you really need to be able to condense your history taking skills down to that 5 minutes. And I mean maximum 6 minutes if you're struggling, but really you shouldn't be going over that time period. And it's moving out of your comfort zone and going, actually no, I need to stop here at 6 minutes and I'm just going to continue with the management. And you have to do this because the maximum amount of points you can get in data gathering is 3. So if you're trying to chase that 1 or 2 other red flags or something else in that history, it's not worth your while trying to do that if you're going to miss out on your management where there's another 3. So to chase that 1 or 2 extra marks, you don't want to lose out on the whole of your management. So you really need to start, thinking about your time management when it comes to taking a history. And for most trainees, I think it's shortening down, which is the issue, rather than you not spending long enough on data gathering. What I want to go back to this idea of making a judgment call. So because you've got such a small amount of time, you really need to question why you're asking the questions you're asking, because every 10-15 seconds it takes you to ask one question, you're ultimately sacrificing the ability to ask another question. So your questions need to be pointed towards something that actually means something. So that might be meaning to work out if something is a serious condition, that might be meaning to work out if in your head, if your management plan would suit someone like this. It's all of those kind of things, and you really need to think about, when you reflect over your case and you're doing a debrief, you kind of have to think, well, actually, should I have asked these questions? Was it worth my while asking these questions? Would I have been better off following this? Now, the beauty is that in a CSA situation, people give you cues, and those cues help to guide you and work out if this is going to become something. And if you can pick up on the cues, you make that decision-making process a lot easier. So a patient will come in and say, oh, I've got chest pain. Oh, okay, tell me a bit more. I don't know, doc, I'm just worried. My father died of a heart attack. And, as soon as you hear that, that is a cue. That is your patient leading you alongside something, and it will come in useful. Now, there's 2 ways to deal with cues, so you work out what works best for you. If you're the kind of person that kind of is happy to go with it, then definitely just go, oh, okay, tell me a bit more what happened with your father, or whatever else you want to ask. A lot of people struggle with that because in your head you've got, I need a history, I need red flags, I need to do my eyes, and this is coming at a time where I'm not ready to deal with it. You cannot ignore it. So I call it park and run. Don't know, maybe I should copyright that little term, but basically the first example, if you're going to go with it, is run. To park it is, okay, I've heard you. Okay, that sounds like that's something you're worried about. Let's discuss that in a bit more. First, tell me about your chest pain. And by doing that, what you've then done is you've literally gone, yeah, I've heard your cue. Mental note, I'm going to come back to this, but let me just go through what I need to do in my head to work out what's going on. That's how you would deal with cues, and that's also what you need to make sure that you're within your 5 or 6 minutes, because then you kind of know, well, I really do need to ask about, the heart attack side of things, or actually, this is quite a young patient, they don't have a dad around, is there something else here, social context? And just having that can really help you manage your entire data gathering better. The last thing, which is kind of related to the others, is what order you go in. So I do, clinical history, red flags, and then ICE. You'll get people who ICE right at the beginning. I found that really unnatural because I was kind of going, oh yeah, what are your worries? And actually, I don't even know what's going on or what the history is. So you kind of have to work with what's natural for you. And I would practice a few ways, but there is no one blanket way of doing this. So you do what seems like it flows for you, because fluency in a consultation means a lot more than these kind of haphazard questions that you're throwing at a patient. and trying to make sure that you've got everything covered. So if you find your icing earlier is nicer, if you find your ice right at the end of that 5 minutes, so be it, as long as you made time to do it. If that works better, then just do it that way. There is no one way of doing it. So we've talked about taking a history, the red flags, we've talked about ice, we've talked about the social side and context of things, and we've talked about examination, as well as a few other tips and strategies. I hope you found this useful. Next week I'll talk to you about the next 5 minutes and management, and I really wish you the best of luck revising.